Well, good afternoon, everyone. It's 4 o'clock. It's 4 o'clock. Goodness grief! It's 2 o'clock in Mountain Time and 1 o'clock in Pacific Time. And as people join us for our conference today, let me introduce myself. I'm Bob Wolverton, Program Director of the Northwest Regional Telehealth Resource Center, and I'd like to welcome you and invite you to take a look at your Adobe Connect screen, and we'll go around and show you a little bit about what's going to be happening today. Uh, First of all, down in the module below the list of attendees, you'll find a file menu. On that menu, you can click on either of those options and download a conference flyer, and I'll give you a little bit more information about the conference in just a minute, and today's um, PowerPoints from Matt's presentation. You can get a PDF copy of those. In the web link module down below that, we have a link to our website so you can take a look at what NRTRC can offer you and in ways that we can help you. And also, you'll find a link to the SurveyMonkey site that gives you a chance to give us some input about today's presentation, as well as tell us what you'd like to see in the future. As it turns out, Martha has found a way of putting the survey up on your screen so you won't have to click through to it. So at the end of the presentation, we will ask you to give us some thoughts, and particularly important, give us some ideas of what you'd like to see in future webinars. Our schedule is still fairly open for the rest of the year, and we can probably schedule in some ideas. In the bottom of the screen, you'll see a chat module. This module we'd like to have you use to share questions and information about the technical process of what's going on today. If you're having trouble with seeing or hearing something, let us know there, and we'll see what we can do to help you. Next to that, to the left, is a question and answer pod. The Q&A pod is a place where you can enter questions for our presenter. And what we're going to be doing today is that we'll be kind of keeping an eye on that. And if you come up with a question that relates to what Matt is talking about at that point, I'll interrupt him, and gently, of course, but ask him to perhaps answer that question at the time, or see if he's covering it in a little bit later portion. And then we just have some notes over here on the far left that tell you different things that you can do with us. Our next webinar will be in April. We're not going to have a webinar in March because we're having our annual conference, and we thought people would get tired of us if we did that. So we're going to have a webinar in April. This will be actually in conjunction with the National Telehealth Resource Center Coalition, and we'll be presenting this one nationally, and so it'll be a week earlier than usual on the third Thursday of April. And our presenter will again be Matt Levi, and at that one he'll be talking about CHI Franciscan's virtual urgent care program, talking about victories and challenges and lessons learned. And I think that's going to be a real interesting and exciting webinar, so we invite you to put that on your calendar and come back and join us for that one too. And of course, I'll remind you, our conference is coming up in Seattle, March 30th through April 1st. We've got 2 full days and an extra half a day thrown in of all sorts of great information, networking opportunities, an exhibit hall featuring some of the newest and latest telehealth gadgets and supports groups and software and such. So we'd really like to see you there. And that's enough of me. You came to see Matt, not me, so let me go ahead and introduce Matt. Matt Levi is currently Director of Virtual Health Services at CHI Franciscan Health. At CHI, at Franciscan, he has also served as Director of Strategic Planning and Director of Franciscan's Project Management Office. Matt's background includes serving in a variety of public health and healthcare settings and not-for-profit boards. So with that, Matt, they're tired of listening to me. Take it away.
Great. Thanks, Bob. Thanks for the introduction. I'm going to start with just reflecting on our patients, who this is really what we all get excited about here at CHI Franciscan Health. And these just share a little bit of an example. We're early on our journey in virtual health services and telehealth services, but already we have, for example, in a day, we'll have 3 patients Currently, military beneficiary patients who would not have had good access to mental health services who are able to receive a telepsychiatry visit from one of our psychiatrists that's in a faraway location. In a day, we'll have 24 patients in our South Sound region who reach out to us for a virtual urgent care service. So looking to receive care either by phone or smartphone or tablet or from their laptop or computer at home. We'll have 481 patients who would not have received a follow-up phone call or a check-in in the past. Now, a few days after their visit to any one of our hospitals or emergency departments or same-day surgery units, will receive that reach out to check and see how they're doing, to follow up if they have any questions about the care they received or if they have any additional needs that have arisen since their encounter with us. And one of the most recent developments for our team is that patients in our hospitals can rest assured, and their families can rest assured, 6,720 patient care hours of remote monitoring are performed by our team in a regional centralized monitoring location each and every single day. And as our services continue to grow, really the impact on our patients continue to grow. And just again, that's really what drives the development of all of our services and really motivates our team to just continue to grow in this area. So to outline what I intend to share today, I'll talk a little bit about changes in healthcare and give you a little introduction to how I came upon virtual health services space and what's impacting our health system here. We're based out of Tacoma, Washington. And we'll talk a little bit more about the response that we've had then, how we've thought about developing telemedicine and virtual health services here at CHI Franciscan Health. We'll talk a little bit about our lessons learned and what's ahead. Really, even under changes in healthcare, the story of CHI Franciscan Health, we changed our name just about 6 months ago. We'd been Franciscan Health System. And 10 years ago, we were a 3-hospital system based in Tacoma with hospitals in Federal Way and Lakewood. We're now a 9-hospital system throughout the South Puget Sound area, and we have clinics throughout the South Sound and into the Olympic Peninsula, all here in Western Washington. We're a full suite of not-for-profit community health system. We have home health services. We have a number of other hospice and outpatient locations in addition to the acute settings. So there's a number of things that are impacting us as a health system, and I'm highlighting just a few here on the screen that really have to do a lot specifically with what's driving virtual health services and the development of telehealth models. But in addition to payment model shifts and technology and data advancements, new consumer-centric entrants and consumerism, really a big theme throughout healthcare for many years has been the constrained supply of healthcare providers and clinicians, as well as a growing demand as patients age through our population. We really face in healthcare a situation where we've been trying to respond to the pressures to reduce the total cost of care. And prior to getting into virtual health services, I was, as Bob mentioned, director in strategic planning here at CHI Franciscan Health. And even 10 years ago, we were talking about how do we as a health system reduce our total cost of care for patients down to a place where, in the industry language, we'd say we could survive at Medicare reimbursement levels. And to do that, we were looking at needing to reduce our cost of care down by like 20%. And broadly, we would look at that as needing to approach it. Maybe we could reduce a couple percent through more immediate cost savings triggers. We've subsequently restructured for our employees our benefit structure. We've looked at supply chain management and other things that we could do to find easy cost savings. Maybe a little bit more of that 20% we've really approached through process improvement and looking at existing services and processes and trying to use tools like Lean to make ourselves a little bit more efficient. But the vast majority of that 20% as we're approaching this really requires a more fundamental shift in the way that we deliver healthcare. And to me, in strategic planning, trying to think about how we approach that shift was what really engaged me to want to grow and to develop the telehealth space for CHI Franciscan Health. It's just in 2012, I read this article that was published by one of the leaders of our national organization, Michael Rowan, and in that he talked about the need to develop systemness. And in a context of an article about leadership, about adopting information technology and medical records and advancing kind of along with some of those other impacts that were in the previous slide, he talked a lot about the need to better standardize, specialize, and centralize a lot of what we do in healthcare. And to me, this also was a trigger that really, as our delivery system and our set of hospitals and clinics continues to grow, we need to be thinking about how we deliver care across the region. And again, this to me spoke greatly of telehealth and the ability to connect providers across any single site of care to reach out to patients wherever they may be. To respond to these changes, yep, Bob.
Excuse me, as you're changing slides or as you're moving on, we've got a question of how many of the hospitals in your system and your expanded system are critical access hospitals?
That's a great question. So for us, we have one critical access hospital, and the critical access hospital for our health system is really about 40 miles even from our hub hospital. So in our situation, the makeup and geography of CHI Franciscan is that we're fairly close, and for any one of our 9 hospitals, we could reach the other within about an hour of driving distance. The critical access hospital for us is St. Elizabeth in Enumclaw, Washington, and that actually happens to fall within the King County, the county where Seattle is located. So it's far enough away from the city of Seattle to gain that critical access hospital status. Responding to a lot of these changes, CHI developed a strategic plan about 5 years ago that really did focus on care across the continuum and a shift towards managing population health. But we recognized that we're not going to get there overnight. And to be able to get there, a lot of the focus of the health system was going to have to be thinking about how do we, in addition to improving quality, improving our workplace, and developing services for population health, how do we help to incrementally be finding ways to improve the cost of care. Maximizing clinical operations really gets to some of those more immediate cost-saving opportunities that better position the health system to have access to resources to be able to continue to grow and also be able to have a lower cost of care that we could be offering to payers or to our patients. We recognize from the need to be looking at how to reduce the cost of care, there would sequentially be opportunities to assume performance risk as we find those opportunities with our commercial payers, and that then we would ultimately be moving towards more of that emphasis of managing population health. And that incremental transition was really fundamental in how we looked at our virtual health service development, because it meant that we're not already able to look at incentives around population health. A lot of the things that we've developed and we're building on have really found ways to maximize clinical operations and then also become a resource upon which to build future virtual health services that really get more at directly managing population health. Also, in changes in the industry, I just wanted to highlight, to me, some of the most inspiring stories that I've gathered and that I continue to share with my team here at CHI Franciscan. I love this from Kaiser Permanente. This I believe was taken from an article, a news article in December. But I looked this up after I spoke with some of my former classmates who have become Kaiser Permanente physicians, who said, yeah, I actually, every one of my follow-ups I now I offer as a virtual service. And I hadn't heard that, and then looked that up, and sure enough, Kaiser Permanente reports that as much as 50% of many of their visits for many of their providers are delivered virtually. And so this kind of follow-up care standard as a virtual option really speaks to a movement and migration for telemedicine. Also inspiring to us is those entities that are looking at consolidating and for dedicated virtual services, creating the space to really enable, empower, and network those care providers to the rest of the organization and to patients. Mercy's virtual center, I believe, is like 120,000 square feet. It pulls together many of their services and will provide care throughout the Midwest to all of their outposts. They've really gone big on this, but I've also spoken with a number of other systems who are creating entities like this, like the Banner Eye Care Center, or others that we've spoken with. For us, we're a CHI Franciscan is an Epic shop, and being on Epic, we and very much desiring to develop a Tele ICU program. You know, we looked at what the dominant market player was, and we looked at other options that have not really taken off in years past. But for us, we looked to Yale New Haven, who really who kind of took a brand new product. In this case, this is showcasing the Epic monitor for Tele ICU, and we're just a first entrant that went ahead and has really made a great use of that tool, and we really see we're kind of following in their footsteps, but finding ways to completely innovate and find new products and introduce them very quickly into the market. Also inspiring are those folks who are delivering hospital-at-home programs. I think that for telehealth, the shift, kind of the all-out shift from even an acute care setting to the home is such a dramatic and radical change in healthcare. Certainly, hospital-at-home program is not appropriate for all patients, but more and more providers are looking at this kind of care and care model that has been out there for a while and thinking about how do we shift maybe not 3% of the hospital population, but is there a way, as more and more of these technologies are developing, to shift as much as 30% of the acute care patients that we have currently serving in the hospital with many, many resources into the home by providing them daily access and visits either in person or virtually by a physician, nursing teams, home health teams, and others that really can be deployed in a more efficient way. And then finally, back to Mercy, I've looked at a number of different models of thinking about telehealth or virtual health. CHI created its own framework, which was very helpful, but I really have more recently embraced this model coming from Mercy Health out of St. Louis, where they're looking at groups and teams organized around what they call Safe Watch, which is really their monitoring type services or things that would be in that command center. Connect Now, which is more like telemedicine and telehealth or video conferencing services. And again, this is in my interpretation here, or Care Matters, which I look at as, you know, more complex programs that get more towards that patient engagement and population health. And as I share the services that we've developed here I really have migrated towards this type of framework because I think it helps cluster like services together and provides a better picture of how those services are working together. Mercy overlaps their circles here because all of them really do integrate and synergize, and I think that's what we've found as well. But being able to organize ourselves in a way like this has really been helpful. There were many resources and folks that we reached out to as we were developing our initial set of services for telehealth. But I think this was a very condensed, concise article that outlines quite a few areas, and every single one of these areas is absolutely key for every service that we've developed. So really looking out in the market, getting a good assessment at any given service, looking internally to make sure we understand what are we doing now and what capabilities do we currently have, what are we looking to develop, how do we align those goals with the organization's mission, and even back to the strategy of the strategic plan. So if the goal, aligning our goals towards maximizing operations, or are we in a place where we'd be able to be looking at even partnering with some of those more population health type metrics. I won't go through all of these, but I think I can tell the story of a lot of those through the services that we've developed. So here I've tried to lay out the sequencing of the services that have developed here within virtual health services. When we decided to form a dedicated team back in 2012, we had a team of neurologists that had just started delivering telemedicine consults, and we had out of strategic planning, a service that we had launched called Franciscan Anytime, which was our version of virtual urgent care delivered specifically for our employees. And so since then, our monitoring services have really begun to grow over the last couple of years. We put a lot of focus on regional telemetry, which I'll talk a little bit more about, and additional services that will be those dedicated staff that are continually providing monitoring functions. Telemedicine services have continued to grow, and I expect, looking beyond the 2015 plus, now we have quite a few models that are going to be easily replicable to every other specialty. And patient engagement in population health has really helped us form many of the relationships that we have across the health system with different care providers. And a lot of those folks that we engaged early on have become our champions for subsequent services. Looking towards the bottom of this slide, clearly these are not exact numbers, but this really does fairly represent the scale of the number of touch points or encounters that we've had through virtual health services. So starting with a handful of employee virtual urgent care visits and neurology teleconsults back in 2012, to adding a set of services and increasing that tenfold, and that's just continued to exponentially grow to where we are today. For ROI models, there's almost there really is a specific ROI for any one service that we've been able to develop, and those have really again started to unfold a little bit in tandem with that strategic plan. So we'll look at maximizing operations through reducing our employee ED visits, which lowers our cost as a self-insured health insurer for our employees, reducing patient transfer as a cost of care, kind of further out, decreasing travel time and gets to that cost of care savings, but reducing readmission starts to get more at that shared savings kind of strategies that have continued to grow. So just to highlight a little bit more of these services, what we have right now is a team of telemetry techs that monitor all of our telemetry patients across the whole region. So this is the continuous cardiac monitoring. What we had before was monitoring provided by each individual hospital. And I'll share the story of how we've consolidated all of those hospital telemetry units into one offsite location that's then networked back out to all of the other hospitals. We have a virtual companion team that's just forming now this month, and this team is an augmentation and or replacement of individuals who are at a risk of falls, may require someone to sit in their room and to be with them to make sure they're not a risk to themselves by trying to get up and out of bed or be at a higher fall risk. And we're starting to work with the bedside team and an offsite video tech who's able to be that virtual companion to keep eyes on the patient, but at the same time coordinate with the bedside team so someone's not always having to be right in the room, but that someone's available to come into the room on a moment's notice. We are currently in the process of developing our Tele ICU, and this is the pay period where we've actually hired our first staff. So we're very excited that our Tele ICU is just beginning here, and we're looking at different models of integrating an offsite nurse into med-surg care. And those conversations are just starting to begin here at Franciscan Health. We provided some home monitoring services, but this is going to be an area where we really focus on probably the majority of our growth in future years. The specific example of regional telemetry is very exciting to us. It's been it's just been extremely successful, and telemetry isn't often recognized as a core telehealth service, but the cardiac monitoring function really has been a nice entryway for us to build a solid foundation that we can leverage all of these other future virtual health services I was talking about. So we looked at the opportunity to consolidate all of those telemetry tech stations into one location to achieve cost effectiveness and reduce variation. And we thought that by doing that, we'd be building the technology infrastructure, the experience, a dedicated team, a clinical leader in that offsite monitoring center, a lot of these functions and experiences that we would need and that are becoming valuable for us now rolling out Tele ICU and other services. Let's see. To develop that, we had a concept in 2012, again when I kind of just came into the virtual health space, and it took a number of years to bring this all the way through. We had outreach to a number of other sites where we were doing our research with consultants and trying to understand what the best practices were for telemetry, and particularly off-site telemetry. And this has just been done so infrequently, it was hard to find back in 2012 other groups that were doing that. But we did a couple of site visits out to larger health systems that had developed monitoring centers, and we started to put together a business plan. And as soon as we presented the business plan for this case in July 2013, we were approved and received the funding from our health system to move forward with this. We were looking at like a 6-month development time frame where we were working across all of the sites and developing workflows, and we really hit a snag right probably a month before we were hoping to go live, where the IT team that was working on how to network this live vitals monitoring really was not confident in the ability of our existing network and at some minor tweaks that had been proposed by the IT team of consistently enabling the live vitals to be streaming across our network. So we had to put things on pause a little bit in everything else except be focusing completely on that network solution, which was reached in April, and then that allowed us to begin construction in August, and we opened in September. There were quite a few things that we had to consider, and I wanted to highlight in this one, just space-wise even. We we were looking at our particular functionality for the telemetry equipment had its own constraints, and we were hearing quotes for different versions of the software that would enable us to do things to consolidate on the screen or gain efficiency in the screen real estate, etc. Ultimately, we had cost constraints that forced us to be locked in at the screens that we were looking at, and so that really meant we were going to have 30-some screens of monitoring, but hoping to consolidate staff down quite a bit. And so we started to look at how are we going to be able to display all of these monitors and be flexible enough that if we have up times or down times, we could flex staff up and down. And one of our biomed engineers talked about the concept of a wall of monitors across the room, which created this early on L-shaped design, and working more with a pretty broad team from construction services, design, IT, and biomed, and the clinical partners, we came up with this kind of hexagonal shape, which you can see our monitoring center in function here. We have dedicated stations, but all of those monitors are on arms, and as different units might become more busy, we created just an innovative solution where we could pull a couple of those monitors together, maybe in between two stations, to create an additional station in between. So really, with this design, we could flex anywhere from as few as 4, or I don't think we would ever go below 4, but all the way up to 7 monitor techs if things were really busy. Other results from this consolidation is because every site had to staff its own dedicated group of monitor techs, we were able to consolidate from 65 positions down to 34 positions. And our original projections was that this would help save 9 positions. So we went far beyond that. The further and more ways we looked at the problem and came up with really innovative solutions, we really found that this was a great way to consolidate those staff. A really great part of this story is that all those folks that were in those other 65 positions were able to, we would accommodate into other positions that we had available or open already if they so chose. So we didn't have any staff that really faced a forced unemployment out of this. So that was something that was also a highlight here. We are currently the largest Philips telemetry monitoring center in the entire country already, and this, for a group that feels so new into this space, this is something that's been really exciting to us. We've logged, this has over 600,000 patient hours, but I think we're approaching 800 patient hours now already over the next week or so. Our clinical response times we're measuring, everything is much more standardized and consistent, and so we're able to really demonstrate the protocols that we're following and the absolute response times that we have. We're able to define very limited hours of downtime, and this was one of the biggest concerns that we had with the technology that we adopted, was that by being off-site, would there be times where the equipment either restarted for kind of a very short-term downtime or for any other reason, and we've really not experienced that happening with our monitoring center. We have had times where in the transition, construction has occurred in the building, and we've had to have a planned downtime. The way that we've constructed this service is that the monitoring center is really the third tier of visualization for the monitoring services. So what occurs in the patient's room is transmitted just as it always had been to the nurses' units and or a centralized monitor tech station at the hospital, and then that transmits out to the monitoring station. And so if we have to go down at the monitoring station, we'll have a planned downtime, or if it did occur unplanned, we'd immediately let the hospital know for somebody to begin monitoring at the hospital at one of those other stations. Staff feedback's also been great. The team out here really enjoys their work. They're not just kind of out there on their own with the monitoring function in the middle of a very noisy and busy clinical unit. They're a dedicated team without a lot of other distractions that are able to be here. And from being at a lot of these other hospitals, it's been really nice to start to form a bond among the monitor techs. So out of that specific example, CHI Franciscan Health also has a lot of, we've developed a number of services within more of the telemedicine consultation and conferencing bucket. We have telepsychiatry that's delivered inpatient as like an as-needed service from one of our very few inpatient psychiatrists to the other outlying hospitals. And we also just this month have begun providing outpatient telepsychiatry consults from an inpatient physician to a distant clinic. We've had a team of social workers that are doing mental health assessments. So social workers at a very busy ED, our hub ED, might do a teleconsultation in the middle of the night when there isn't a social worker at our critical access hospital or some of the other smaller community hospitals. We have a transfusion-free medicine team, and this is a team of nurses that provide informed consent to patients that want to forego blood transfusions as they come in for surgery. And so where the system had been struggling with the growth of this service to many different locations, this is a great way to continue to have a great program, a dedicated team, and be able to access and serve patients at any one of our hospitals, but without having to have boots on the ground at every single hospital. We also have a neonatology, a number of NICUs in our system, and the NICUs, as a neonatologist may be at one site or the other, or nurses want to share information. We've set up video consult stations at the NICUs so that the teams can connect and talk to each other. I think early in our development, we talked about neurology, and we're currently actually on hold with our neurology team. And I really think that in the state, Washington State, if we can start to see movement, as we see movement on that telehealth bill and we get better reimbursement, our neurologists are so busy that this was something that became infrequently able to be delivered. And because of the infrequent delivery of the teleneurology service, I think there was a concern that we were really not being as proficient as we wanted to be with that. So we're hoping that as there's more of a model that can be developed and sustained, that's another service we could bring back. And we're also working with surgical teams and pulmonologists on those services as well. Our team, our health system had shied away from video consultation. So we were one of the health systems that would not have had a strong video presence in conference rooms prior to about 2 years ago. But as our team has developed more familiarity with audio-video systems, we've been able to install 7 going on 9 really strong, nice video conference units in conference rooms at different campuses. And this has already really helped with education services, training for Epic, and working with some of the teams that needed to, particularly of physicians needing to work on the development of Epic for us to kind of have that collaboration across sites, as well as things like our tumor boards and CV boards to really connect particularly our clinicians across various sites. The last category of services was patient engagement and population health. And so we have been in this space for a little while with Franciscan virtual urgent care, so I wanted to just highlight that story at a high level. So I'll share that example. But we have a number of others we've been working on and rolled out as well. Cipher Health is our service for reaching out and contacting patients after they have been in our hospitals or emergency departments or same-day surgery units. We ask them a set of questions and to better understand how they are doing after their visit and how their stay was with us. And then that information flags or triages back to folks that can help them out. That same system, we've gone from the follow-up approach to now real-time nurse unit rounding. And so that same system, same database, same technology is helping to enable nursing staff that are rounding with iPads in the hospital units to capture real-time feedback from patients and then triage or flag notes to dietary or pharmacy to let them know patients' needs in real time that can be responded to, and if service recovery needs to occur in real time. That's a great data-based technology solution that's enabling the clinical teams to better communicate with each other and keep a data set of what's going on. We also have we're just wrapping up a year-long virtual diabetes management service pilot with a select subset of patients that a team of caregivers for us had come together, and we worked with, based out of two of our primary care clinics, working with those physicians and a team of diabetic educators, care managers, and other folks from our team. We put together a program where higher risk diabetic patients have received much more intensive touch points with the diabetic educators and health coaches for weekly virtual visits, for daily health checks, online education modules, group classes that are online, and real-time monitoring or not real-time monitoring, but in-home monitoring that then feeds into a team of 24/7 nurses that can respond and check in with the patient if their glucose levels are getting out of control, or just to be able to have that real-time feedback with these diabetic patients. We've been very excited about that service, showing some great results already. Every one of these very out of compliant patients that were struggling to bring their hemoglobin levels into the ranges that we wanted, we've seen kind of universally patients have really responded to this program and are showing great outcomes. And we have also seen a great reduction in the measurable cost of care for us. So we're excited about our first cohort of patients that have gone through that program, and we're excited to be working on and developing our next iterations of that, which will get more towards the foundation for intensive chronic disease management, moving beyond just diabetes management into other conditions. The example of virtual urgent care for us began with our launching of a service in 2010, which actually was, well, I guess I've got my timeline there, so I'll just highlight what this is being able to connect with a primary care physician or nurse practitioner by webcam or by phone within 12 minutes to have a consultation about an urgent condition, to receive a triage if that's appropriate, but really the intent is that we've found about 75% of patients can have a complete consultation with the history, diagnosis, a treatment plan, prescription if necessary, virtual urgent care visit. And then we have included in our development of this really seamless follow-up to be able to refer patients back in, book an appointment for them, help them connect with a new primary care provider, or otherwise have their needs met in a way that's very friendly to our primary care practices. So to our timeline, this has been a many-year unfolding. In 2010, we started to look at how to provide better access like this and to use this as a differentiator for our primary care clinics by offering this to our clinic patients. And we did some market research and we did some focus groups, and we thought that what we were going to be successful at was offering a Netflix type model subscription service. Folks weren't as interested in paying the full amount for the service before they really understood what it was, but they kind of understood what it was like, and they thought, maybe I'll pay, I might pay $10 or $20 per month like a subscription service, and be able to then have access 24/7 to a service like this. So we actually launched a pilot like that back in 2010, and we had no patients sign up for the first month, and I think the second month we had one patient that signed up by accident, and when we found out and we contacted her because she was our only patient for a while and we wanted to know how things were going and what was it that really attracted you to the service, we found out that she hadn't quite understood what we were offering, and we helped her unenroll from the service, and we really went back to the drawing board and said, gosh, how do we start to get better experience with this and start to build better partnerships with our clinics and our employees, and get a better understanding of patients in a more protected environment. And so we actually launched in 2012 a restructuring of the clinical team and the concept by offering it to our employees. And that really allowed us to gain a little more than a year's worth of experience before we came back to the table and said, this is getting great feedback from our employees. We are seeing this as a reduction of emergency department visits, so that value is clearly there from a end game total cost of care perspective. We're getting great patient satisfaction feedback from patients. So we began to look at how to integrate that into our clinics after hours. And so that launched as an offering to our existing patients out of our clinics in 2012. In 2013, we expanded that 24/7 through a web portal. And now we've been working to expand that with broader marketing, as that's kind of gained ground, as well as we're currently integrating our employed providers into that service and starting to add additional access points. This just shows the main landing page for our health system, and you can see the virtual urgent care service is really highlighted right on the main landing page of the site with a link right there. We've seen that this has brought us patients that had never been our patients. Excuse me. And so thereby building our primary care practices, we've seen the number of virtual care patients, or patients that we call engaged patients who come to us, has been growing over time, but we've already served well over now 6,000 patients. And the majority of these patients are commercially insured patients. Many of them don't have a primary care provider or don't feel connected to their primary care provider and are open and interested in connecting with a new primary care provider. And then we've, by including this as part of our strategy, really been able to help a lot of these patients to book a new appointment to establish care with one of our primary care providers. This isn't like a requirement of the program, but we make it very easy for that to occur. And that just builds into our patient engagement population health strategy of having a service now that reaches out and is a new front door to our patients. The response for this service has been very good. We've had a 12-minute response time, 12 to 12.5 minute average response time with our providers. We've had great positive patient satisfaction feedback. And of note, we're constantly asking, we survey every single patient for this service, and we ask them what they would have done if it hadn't been for this service. What I have here on this slide are the patients that come in through the online web portal. 21 patients said they would have gone to an ED, 52% of patients said they would have gone to an urgent care center. What I always think is very interesting about this data point is that for our employees, we've really marketed this differently as an emergency department avoidance. The 52% on this slide, I think, speaks to a lot of the advertising we have online that then directs folks into the web portal. And the advertising is focused on folks that are looking for urgent care, maybe with a with an urgent care Google search word. And so I think part of the marketing and the offset to me really says that you sort of get what you focus on. And so by targeting ED avoidance, we've seen more of that with our employees. By targeting urgent care patients, we've seen a lot more of that with the broader community population. There's a lot of lessons learned, and so I just wanted to share a few. I am so excited about virtual health services and telehealth because this is fundamentally, I believe, clinical care more than technology or IT. This is about working with our clinicians and our caregivers and getting to the heart of the workflows that they experience each and every day, or getting right to the heart of patients and meeting their needs and being able to connect them with providers regardless of wherever they are, and building that culture and those relationships, helping create a shared vision and find value for each and every one of these services is 90% of what we do each and every day. These services also get right to the regional delivery of care. So even in our example of regional telemetry, it's not just consolidating them and within those four walls having a regional team. It really means that we've standardized that workflow and process, at least for that particular part of our continuum of care, across all of the region. It's allowed us to see things that were non-standard and identify best practices and start to pull those things together. And this allows us to connect sites of care across the entire continuum. It also gets to evidence-based practice. So as we look at best practices, or as we look at how we can really maximize the value of some of these new approaches, we rely heavily on making sure that we're following the best evidence-based practice. For team and infrastructure development, just speaking to the development of our services, we currently have 80 team members of virtual health services. 6 months ago, when we launched regional telemetry, I think we had 35. Prior to that, we had 7, and a year ago, there were about 3 or 4 of us on the team. So this has been rapid growth, but intentionally rapid growth, to think about what are the services that are going to allow us to maximize those operations, but also for our team to be able to start to build some of those fundamental components that now we do have a clinical operations structure, we have a clinical leadership structure, and as more and more services develop here within our team, we can leverage those existing resources we've already built, we've already justified, to be able to offer additional services off that infrastructure. The network that we built for regional telemetry, we're able to leverage the same strategies, contracts, contract approvals to be able to live off of a dedicated clinical network infrastructure for our health system. We've also found that things change and morph, and we've had to think about how not to try to do everything all at once, but to come up with an incremental approach and to possibly approach things in a number of different ways and then put them together. The virtual diabetes program, I don't think would have been successful if we had not made a lot of headway already with some of those specialists doing the telemedicine consults, or for delivering virtual urgent care to patients in their homes. So that multi-pronged approach really allows us to build and create some synergies of experience. And we've just had to stick with it and have a lot of tenacity. So what's ahead is strengthening those partnerships with our clinical teams and support services, continuing to build our team of people and processes. And I'll show you our clinical operations structure as it's developing here, I think on the next slide. And advancing our clinical tools and IT network infrastructure. So not only that network, but now starting to think of if there is something that happens in one of those services, we're developing the protocols and helping to make sure we've got those strong partnerships between our team, IT, biomed, and others to be able to more quickly resolve those each and every time. And I think, too, that there are such great opportunities for telehealth to be partners with home health care, patient access, and care coordination, so that really we're just eliminating those geographic and distant barriers between our patients and our care providers. So the better we can do that with a virtual option, that's great. But if we can send someone to, if we need to escalate to an actual home visit, we want to be strengthening those partnerships. And if there's a way to better coordinate with our care coordinators or our patient access team so that patients can find us and connect with us or connect with other care providers, we're really excited about creating those opportunities. This is what we're creating for now, this growing team of dedicated virtual health center staff. We'll have specific areas for telemetry monitoring, for Tele ICU monitoring. We've got the spaces for virtual companion and some of our administrative support, and creating kind of that overall teaming environment so that folks can feel like like they not only have their protected space for their job function, but that the space is amenable for people to pull each other in and get some advice if they need. We feel that having very experienced RNs in there with the telemetry techs can allow them to ask for help or to ask somebody to check on a patient that they're not quite sure about. And so that cross-pollination of specialties is something that's very exciting to us. To that kind of virtual to home health escalation, our virtual center is located in Tacoma and is right at the crossroads of Interstate 5 and Highway 16 that goes out to the Key Peninsula. So we're very excited that even the monitoring center is regionally, centrally located, offsite of a hospital campus, but very convenient access if then care providers do get out into the community. Just a final thought for the presentation here. This comes from the same article that I referenced earlier by Michael Rowan, where he really just was calling upon in healthcare thinking about one of the greatest generative questions, that being, what do we need to know more about as we look to uncertainties of the future? And that's really, I think, what sparks a lot of the innovation that we have in telehealth. For us, we are looking for those great business cases and building these services. But what's behind that initially is often trying to think ahead to where are we going with care redesign of the future and building that continuum of care, and how are we developing the appropriate knowledge and toolkits and teams and infrastructure that's going to be able to enable that shift to population health. So thank you for letting me share a little bit of our story about CHI Franciscan Health and our development of virtual health services. And Bob, I don't know if there's a couple questions that have come up, but I'd be happy to spend the last few minutes we've got here or go over, even if there's a couple questions from the audience.
Yeah, Neil is peppering you with questions. I'll give you a heads up. He's one of our board members, so you can expect that from him. But he's very interested in your diabetes management program and wondering if you have detailed information on it that would include staffing, capital cost, personnel, outcomes, etc. And as far as that one, I don't know if you have it off the top of your head. If you don't, I'd be glad to get you together electronically to share that one.
Sure. I'll just speak a little bit more about it now, but Neil would be happy to follow up with more detail outside the webinar. We started with a very small population. We weren't intending this to be statistically valid, and the care from this has been fully funded as like a performance improvement project by the health system. So that out of the way, we really started with 25 patients. Again, not meant to be statistically valid, but our care teams, we've had diabetic educators that in their day job provide diabetic education, and then have really partnered with this service to really care for these 25 patients. We're working again with physicians and care managers out of the primary care clinics that we've been partnering with to do this. And so the staffing model, staffing costs, honestly we've gained a lot of experiences I can share with you, Neil, as we've concluded a 12-month pilot period. And we're rethinking about, what is the right mix? Maybe some of those more intensive services weren't as necessary for the length of the program. And some of the things that came out were like, we really started to appreciate the value of text messaging. Our patients really, even our even elder patients that were in that population, really responded to text messaging as preferable to things that we had on tablets for them in their homes prior to that. So key indicators for that, though, have been clinical, so looking at things like hemoglobin levels and getting them in control, as well as cost. And so part of the criteria for going into this program were cost thresholds and utilization thresholds the year prior to entering the program. And we've seen literally since enrollment with these 25 patients, and now as we've completed the 12-month mark, 0 diabetes-related inpatient admissions, ED visits, and urgent care visits. So again, it's not a statistically valid or intended to be that way, but we've seen very very positive response from these 25 patients.
That's really cool. Neil would also like to know if you're forming medical homes and ACOs within your system.
We've been participants in the patient-centered medical home initiatives as a health system, and so I believe all of our, at least our larger primary care clinics, have gone down that path, and we're seeking that credentialing over the last year. So we want to support that out of services like this, and we have an ACO within Franciscan Health System and have been talking with them about how to really get more into telehealth with the ACO. The ACO hasn't had a lot of those clear entry points for us yet to engage and to have those payment mechanisms kind of worked out. So I'd say we're at the table, but we're still dating.
Well, great. If anyone has further questions for Matt, go ahead and enter them in the Q&A pod. Otherwise, as we're kind of winding down here, I want to thank you all for joining us and ask you to take a survey on today's presentation and especially what you would like to see in the future. We're here to provide whatever information and education we can for you folks. So please let us know what you'd like to see on down the line. And if you will going to be at our conference in March 30th at the Olivate Hotel in Seattle, Matt will be there and you can back him into a corner and ask him all sorts of questions. Well, I don't see any further questions coming in, Matt, so I just want to thank you very much for joining us. And what a great story you've got to tell. I'm just so happy to see what's going on with you folks, and I'm glad that you're in my region, so I can claim to be associated in some way.
Thanks, Bob. Thanks for letting us share.